Good evening, TNT family. We are back with Yellow the Code, and Dr. Ramropers is here with us again. Fortunately, we are fortunate to have him out of his busy schedule, and also Dr. Parum is here with us, and Suman Singh is here with us also. And so, one of the things I want to address is the TTNNA addressing the government and saying that we cannot afford to open the Cuba Hospital. For me, that is total nonsense coming from a person like that. So, Dr. Ramroop, I just want to get your opinion because I'm very disappointed seeing that coming right off the bat that Mr. Edie Stewart could come up with such a horrendous kind of statement. I think it's totally ridiculous. And he should have been making an effort to assist the government, in trying to open the Cuba Hospital and bring in more medical staff. I should have seen a greater commitment from such a person, and I'm very disappointed in seeing this person. So I would like to get your opinion on that, and the others guys can jump in after that, please.
Yeah. The nursing fraternity is a very important group of people. They have been they are the ones who run the hospitals. And one of the problems we have, I will give you a little example and answer to that question because I think it's something that you need to know and it's something that is very important. I remember when we had the old casualty in the San Fernando Hospital, right? And we had a CEO there, and I was actually an orthopedic in the orthopedic surgery department, and they asked me as a young registrar who came back from England with my fellowship to see if I could be set up what is called a level 3 trauma center, a level 1 trauma center in San Fernando Hospital in a new casualty, right? So what happened is we moved from that old casualty that we used to have up the hill. I don't know if anybody remember San Fernando when you go up the hill.
Yes,
Right.
I remember that.
Yes, and then we moved it to the current facility that we have there now. And they had nice operating theaters and things. So they wanted me to commission the new building in terms of opening it up. So when I went there, the first 2 days, I noticed something. I noticed that when people come to the hospital and they go to the casualty department, there was a line and they had people lining up, right? And when you are talking to the nurse, the other people from behind was listening to the person in front. In other words, there were long lines. And there was something, if most of you all who work in the emergency system, you hear something about triage. So what happened is that there were serious people who were in the line, and there were people who just had a problem who wanted a sick leave or wanted their toe was hurting them or a cough and cold. But there were people who had symptoms of heart attack, and they were all lining up. In other words, they just came in a line. They had no prioritization, you see. So I went into the emergency room and I brought all my doctors together and I said, listen, we want to change up this whole system where you first come, first serve to a triage system, right?
Mhm.
So what I did is I called the chief nurse of the casualty department, and I said, could I meet with your nurses and my doctors? We want to have a meeting early in the morning, right? When everybody comes to the shift, maybe about 7:30 before everything gets busy. So we had a meeting and we explained how the triage will work. So we said, well, look, I could give you all about 3 weeks. I wouldn't rush you all. I'll give you about 2 to 3 weeks to change the system. We explained how it will be. We changed up the levels 1, 2, 3, 4. We told them how to come in. The ambulance will be level 1. Level 2 will come in through the ambulance, be like a heart attack. Level 3 will be the hub of the hospital. A guy, people sick, you don't know what is happening with them. They come through the front. Level 4 and 5 being like somebody with a pain in the toe, right? And 4 being somebody who, just like they got a cut in their hand, but it was very, very, very tiny. So in other words, and we told them. We had another meeting after 3 weeks. We said, okay, we would like to see you. We'd like to see you do it. Listen to me. After 1 month, it was not done. I tell you, nothing. Everything was the same. So after that, we wrote a letter to the medical director. We wrote a letter to the matron. We went to the matron. We talked, and still, after about 2 months, nothing happened. So one morning, I got annoyed, and I told my guys, "Listen, let us go." I put the doctors in front, I told them, let us triage and send it to the nurses in the back. And we what I tell you, we run that hospital, that casualty department in about half an hour. We made everything beautiful, like a first world hospital in terms of triage. You know what the nurses did? They all, I don't know what it was. I don't know what kind of communication they have. I mean, I didn't see these people have phones or anything. It's just like there was a subtle communication that transcended space and time. Listen, within minutes, all the nurses from San Fernando General Hospital casualty walked out of the work and went to the matron's office. They shut down the whole casualty. Needless to say, I was brought, I was put on the coals. I was brought over the coals. I was, I had the CEO came down, everybody came down, and it was a big thing. Nurses, stopped working in casualty, and I tell you, I was to blame. I was a big problem. And when we finally came to an agreement and we put the thing in place after a few days, the nurses, I had to, what I had to show them? I had to show them the minutes of the meeting I had with them, which I did, thank God. I had to show them all those who attended the meeting, right? I brought out a paper that showed every time they came to the meeting and we told them what we had. I had to show them the process of what we had to do to implement the triage system, which is currently there now in San Fernando because of that, okay? In other words, then we created legacy there. And that was the only way that they had to backpedal, because you know why? We brought them in, we talked to them, and we told them what they needed to do. In other words, then we had the evidence by which we could have told them that they could do this. And when I became medical director, we had the same problem with overcrowding on the ward. So I wouldn't go through the details, but suffice it to say, what has to happen? The nurses have a particular system, and here is where the shortage of staff comes in, right? They have a lot of senior nurses who have gone through a lot of time now, right? And they reach a stage where they are what we call SNs, all right? The RNs are the registered nurses. They go through also the time to become SNs. So what happens on a lot of the wards now, you have a top-heavy system where a lot of SNs and senior RNs, they just work the day shift. They come in from 8 to 4, right? And what happens is a shorter amount of staff works the afternoon shifts. So what you have is a relative shortage of staff, because what you really have is the senior nurses and the senior RNs not really working the shift in a hospital as they normally do. And this has actually come, I mean, I worked in hospital for over 20 years. I know exactly what happens. So I remember going to the Registered Nurses Association when we started the triage system and we wanted to do it nationally, right? We had to beg for the support. So when we had to go to the matrons, it was almost like a fight to change the systems in the hospital. There was a constant fight that you always have to try to explain yourself. And although it's working good, you always felt that there was a sabotage, that there was something that had to happen that was wrong. And that was one of the pressures we had as a medical director. Now, here is the problem in the hospitals. The doctors actually work in silos almost. And the nurses actually work in silos almost. When you say that there's a head of the department, there's no real head of the department, because the doctors are really heads of departments of the doctors. And the nurses really are heads of departments of the nurses. So what you don't have is like when you have a ward where you have a doctor, a nurse, the attendants, everybody come together for a meeting, that is also a problem. So there's a systematic problem that has to be re-engineered in hospitals, right? Where you have a team approach to healthcare. Now, that is why the nurses can come up now and tell the government and the country that there are no pediatric nurses to go to the Cuba hospital. The reason for that is that there has been no significant, although you have a nurse in charge of the RHA, like a senior nurse who is the nurse director, the director of nursing. Okay, and you have, when I was in Southwest, this is what you had. You had a director of nursing, and in the hospitals and the senior health centers and health facilities, you have matrons. These are the senior nurse in the floors. The matrons, and now will have reporting to them all the SNs and of all the different lines of service, like gynae and pediatrics, and there were about 15 lines of service: surgery, orthopedics, ENT. Those are called lines of services. Mm-hmm. Each one of those have the registered nurses in charge and senior nurses, and the senior nurses will have a meeting with the matron, and the matron will actually talk to the director of nursing. Now, that whole system is actually very solo. only time it comes up is when the CEO had what we call the technical heads meeting, when all the senior heads of different ages, like the radiology, the senior daily paid staff, and the engineers, and the doctor, the medical directors, and the senior, the director of nursing, and the head of finance. These are the technical heads. So they come together and they begin to share. But there was no sort of team approach whereby the nurses would say, look, we need to begin to train pediatric nurses. We need to begin to train critical care nurses, right? We have just a nursing class here, and they're just training out nurses who will become registered nurses and senior nurses, and they will work on a ward for years, and then they will switch them around to another ward, and that's how they get experience. So this whole system of nursing, right, the government, right, really needs now to sit back a little bit and bring everybody together and say, look, this is the team approach. We have Couva Hospital. We have X amount of pediatric nurses in the hospital. Some of them might not be coming to work in the evening or in the night because they reach a SN level. So although you might have worked on a pediatric ward in San Fernando, of course, there are senior nurses who worked on pediatrics and neonatal wards in San Fernando who now and come work 8 to 4, right? And they don't work on call in the night, because the other nurses who are the junior RNs and some of the training nurses will work in the night. So you have quite a lot of nurses who are there at the higher level who can actually not just impart knowledge in training schools or whatever, but they can actually work on a shift basis and come back to work in hospitals like the Couva Hospital. So within our own system, we just have to kind of, and I'm telling you, there is the capacity within the country to do that. They don't even have to go to the Philippines right now to get nurses. But as somebody put in one of the posts I noticed, we don't have any borders that are locked or whatever. People can come in and go as they please, except the Cuban nurses, of course, because we might have some problems with POTUS. But the problem is that, yes, you can go to the Philippines, you can recruit nurses. Of course, you have to have attractive packages for them. And, within the space of 3-4 months, by the time you get your foreign affairs minister and your minister of immigration and all those sort of work out the little contracts for them, you can have the Couva Couva Hospital commissioned within the next 3 to 6 months, right? With at least a phased operation. So that is what the Nursing Association should have said. They shouldn't have said, no, we can't do it. We can't do it maybe now. But we have to look back at our systems, look back at our capacity, right? Try to find out exactly what capacity we have in the health sector, where we can move certain people from here to here. Because how you can have a building for 10 years, with all the resources in the world, it's very strategic. I mean, although somebody is saying, Mr. Stewart is talking about, you have pediatrics offered at San Fernando, pediatrics offered at Mount Hope. If you have extra beds in pediatrics, it's not something that it can waste, because I think Herschel Ramos, one of the attorneys, I think, wrote on a post today that, yes, you can actually have a regional center for pediatric management at the highest level in terms of pediatric surgery and operations for pediatric patients, you see. So it can be a regional approach to pediatrics, and you have regional pediatric nurses who can come down. You have a big UE campus there doing nothing in Debe, right? You can restart some of the training schools in nursing, because there's a big problem all over the world, a shortage of nurses. And I personally think it was not a nice statement to make, especially as a government has come in. You already knew that the Honorable Prime Minister is saying that she is going to open up that building, right? I mean, it should have been one of support and saying, well, look, yes, we would work with the government. We will try to see what capacity we have. We can actually sit down and look at the logistics and look at the operations, look at the competencies that we have, and see if we could phase it on a phase basis. We can begin to have some of the patients, all right, and we move forward. Yeah. So I am not happy that it was said. I do think that it was unfortunate, but I don't think it was a problem. I think it was expected. Someone talked about that's what happens, but the nursing fraternity is very, very strong, and it has I wouldn't say political. I mean, to go and say that will be politically incorrect, but there's an inbred mental blocks within it, as I experienced personally when I had to introduce a triad system and I had the whole nursing San Fernando casualty walk out on me. It was such smooth and graceful that you didn't even know it was happening. I mean, I was so amazed at how they moved on that day. And that's beyond communication. Now, we didn't even have cell phones, using at that time. I don't know how they did it. It was amazing.
So it was like a smoke signal or
Yeah.
telepathic
Well,
communication.
I think even the Apaches and them were not as efficient as what I saw in that casualty. I mean, these nurses were working behind walls, and all of a sudden you just see every one of them walking out through the casualty department down to the matron's office. My heart dropped to my feet, you know.
But
And
knowing the fact, right? Knowing the fact of the situation, knowing the fact of what we're trying to do in the country, and to jump up right away and run to the press instead of trying to meet with Dr. Budo and say, well, this is the deficiency we have a problem, and we will need to do this and that. You jump up, showing your red T-shirt and your party card, as far as I'm concerned, that you intend to stall and obstruct this government in any which way you can. And I mean, that is for me, and it's totally unacceptable. But I want to welcome Farida. Farida, can you give us an
Hi.
update as what's happening with your mom? I know you might have to leave us quickly, so I want to give you some time to
Yes.
kind of give us an
Um,
update.
well, well, at San Fernando, they give us a letter to go to the district health center for dressing for the foot. They really didn't do anything to the foot at San Fernando, but I must say they did good at San Fernando for the hand that was burnt and with the intravenous thing. But otherwise, nothing is being done. We're supposed to go to Mount Hope on the 15th for her clinic day, and she is so scared she doesn't want to go, and the foot is getting worse. So even at the health center in Freeport, they ask, what are they doing at the hospital? Nothing is being done. Just, keep putting her off, come back, come to the clinic in a couple months, a month and a half, and she go there, sit for a whole day to just say, come back again. They look at the
Yeah.
foot and, it's since January been going in circles. The only thing they did was she had an angiogram done, and that was it.
So the
Just
angio was done at Mount Hope recently, the one that they sent her to do.
Yes, it was done at Mount Hope.
And any feedback on
Yes,
the
we
results
went
or
to
anything like that? Any
Well,
feed-
nothing yet so far. Well, they said circulation is still bad, and well, they haven't done anything in Mount Hope since after that. And she, as I said, Gary, before the week before Easter, the Monday, we took her in emergency because she was, she couldn't walk, and they had her there from Monday till
Farida, you're freezing up. I don't know if you hear me, but you're freezing up. But
to go to
we have two doctors here with us here tonight. We have both
the
Dr.
washroom for
Ramroop and
somebody
Dr.
to take
Parum.
her to the
Yeah, maybe you can go off camera because
washroom.
you're freezing up. You're freezing up. So try going off camera and see if it will help to with your data. Um, so, gentlemen, we have a situation here where the operation took place and foot is deteriorating, and you know we need some assistance and recommendation with this situation. Until our government gets, it's going to take us a little while to get set. But I mean, this is very sad to see happening in the country and the lack of care and how much we need to upgrade. Dr. Ramrup, you want to jump in here for a little bit, or Dr. Parum? Dr. Ramrup, how you feel about this?
Well, I mean, maybe the other doc could talk, but I think that was the case you had asked me to look into,
Yeah, the
and
picture. Yeah.
I saw the gangrenous too, and her other comorbidities, and I think the hospital definitely would have done most of what they can do with her now. The problem with this type of infection, it is related to the blood supply, to the toe, and therefore there are two types of gangrene. We call dry gangrene and wet gangrene, and we have to be very careful, because if it's dry gangrene, we tend to want to try to leave the toe, because as you cut more and more, it just keep going, because it's circulation. You have to sort of map the circulation to the lower limb. The problem is that in this patient, she would have had something called peripheral neuropathy, and the vessels, she has the fine vessels, we call it the microcirculation. There's calcification of the blood vessels, to put it simply, and this sort of hardening of the blood vessels in the presence of the peripheral neuropathy due to diabetes would cause significant problems with the circulation and the nerve supply to the foot. And as an orthopedic surgeon, I do treat diabetic sepsis in my clinic. And before this, I was a trained general surgeon before I went into orthopedics, and we did quite a lot of work on Ward 6 in the hospital. I don't know if you ever been to Hospital San Fernando, but I worked with Steve Budram, and we used to do a lot of amputations, and we saw a lot of these cases. This is a very common presentation in the hospital. I remember as a student when we worked with Professor Vijay Narayan Singh, there was a lot of emphasis that was put in over the years from the Society of Surgeons and other persons who in different hospitals with respect to setting up these diabetic care clinics, where people like this patient would come in and see a surgeon, or see at least a junior surgeon, so that they can have regular inspection and have what we call debridement, which is really cutting out of the necrotic tissue on a timely basis, so that the infection doesn't kind of keep there as much as possible. You want to get rid of infection sites, right? Infection areas in the wound, and this will allow the wound to heal faster. So two things here. I think that the treatment that is required right now is health center treatment, which is basically dressings, and to monitor the toe to make sure that it remains dry. If it has already been excised and cut off, from when I saw the pictures and they did do an amputation of the toe, then what we have to do now is to look at the dressings to make sure it doesn't get infected, and hopefully it dries within a period of time. The hospital is a tertiary care center, and the health centers are supposed to be equipped with the doctors and the nurses and the competencies, because there's an easier access for the patient, less waiting time, less bureaucracy to get in to see the surgeons, and the dressing is what they need now. But what is most important right now is that once the health center or the patients at home, or the relatives at home detect that there is a change in the toe, and it begins to ooze more, becomes more wet, smell more, there is more swelling around it, that the patient has to they have to have easy access back to the surgical ward, where the surgeon can look at it and do a procedure, and again send it back for dressing in the health center. So guys, the problem here, in my opinion, and of course the hand, well, that obviously is what we call an adverse event. It mightn't be negligence per se, because these things happen, but when they happen, an adverse event is that a patient comes into the hospital and should not have had this problem if it was monitored and treated properly. Doctors, especially in persons whose hands are swollen, whose veins are very tortuous and whatever, you do miss the veins sometimes, and the fluid does go into the tissues. That happens all over the world to the best of us. But when it does happen, the fact that the person is diabetic, has decreased circulation, has the neuropathy, right? If you know what I mean. So you will expect that this extravasation of fluid in the tissue, that it would have problems, and you have to monitor it carefully to prevent it from happening. So in the proper management of wounds to the hand, especially the wrist, right? The standard professional and expert standard of treatment is that you would have to elevate that limb, right? If you go on a ward and anybody who gets a cut and you have what is called cellulitis of the hand, and the hand is red and swollen like a big balloon, you have to elevate the hand so that the blood and the fluid drains back into the heart, so to speak. It must be at higher than the level of the heart. So that hand should have been elevated 24/7, only coming down for exercises. It has to have physiotherapy. You have to call the physiotherapist onto the floor so that the physiotherapist will do the exercises with the elevation, right? You have to, don't use antibiotics, because if you use antibiotics, you don't use antibiotics until you identify an infection. Use of antibiotics has been abused all over the world, including Trinidad, where you use antibiotics to prevent, but you should really use antibiotics when there is an infection. Sometimes you have to use it prophylactically, like when you're going to do surgery or you're going to put in an implant when you know you don't want infection. But in this case, you would have had to wait, elevated painkillers, right? Make sure and let the person have therapy to prevent what happened in the hand. I think that the treatment of what happened in the hand is bad, but the dressings is fine. From what I saw, nice and red. It's granulated, meaning that it's healthy. It's almost like a fresh burn, right? It's looking good in terms of healing, and that can be dressed in the health center. But the biggest problem here would be stiffness. So,
Yes, she's getting that problem. She's getting that.
stiffness. It will be very stiff, and it'll be a big problem to hold things and whatever, unless there's some physiotherapy. Even with the wound, she needs to have aggressive physiotherapy. One of the biggest problem with hands and fingers is that if you don't do physiotherapy, physical therapy in the healing process, it becomes huge, stiff. The tendons become hard, and then you might need to hold a toothbrush or toilet paper later on. So it's very important that physiotherapy be part of this patient's rehabilitation. So in terms of the further surgical care, as I said, it is a very important thing that one of the most important things that a doctor should do in a clinic, in hospital, or in the health center is to sit with the relatives and explain, take the time and explain everything that is supposed to happen or will happen or could happen, and to identify some of the indicators or what we call the signals or the symptoms that will occur that will allow you to go back with this patient to see the doctor. Having the patient in hospital all the time, right, for that care, it would not happen, because there are other persons who have more serious problems who might die if you don't have a bed for them. So what you really have to do now is to look at this patient for a number of things. One, infection in the foot, if it is oozing pus, if it is extremely swollen and oozing, if the black gangrene is changing into a sort of wet gangrene, if the blackness is going up further into the foot, it means that the circulation higher up is being lost. So that when you once you start cutting with these black toes, you end up having to cut more and more and more. So the trick is to try to let it be dry gangrene, so that what will happen is that when it dries off, sometimes it just falls off. It doesn't pain. It just drops off, because it just shrivels and drops off like a dead piece of tissue. It is when it becomes infected, that's when you have to start chopping. And once you start cutting, you end up cutting more and more and more. The foot has to be elevated. I mean, this is probably one of the most important things from what I saw. It has to be elevated above the level of the heart. So when a person is sitting down or they lying down on the bed, it must be on 2 or 3 pillows. Now, all of this conversation that I'm having with you, it should have been done in the surgical ward upon discharge. There is a process in all the centers of excellence around the world, which is something that is important for what we call an accreditation standard. If what I just said to you has not been told to you, it means that we had a conversation a couple of nights ago about accreditation standards. It means that Southwest Regional Health Authority has actually failed with that particular accreditation standard, where they will sit down with you, the discharge nurse will sit with you and explain to the relative all that I told you. What are the signals? What are the symptoms to look for? What is expected of this person? When to bring her back? How could she access us back very rapidly, just in case it starts to spread up higher? This is the problem that will they The bad treatment that you have is not so much the treatment that you got for the surgery and cleaning and cutting. That's not bad treatment. That's good
No.
treatment. If I have to do a forensic analysis of this based on what I saw, that's good. The bad part is the counseling, the advice, the inability to have a proper discharge summary to explain what to do if something happens. And that also has to be done at the health center. When she enters the health center after her first dressing, this same conversation has to be had. This is the more important part of medicine.
Mhm.
This is what makes the difference. This is the quality approach to medicine. And if this is not done, I tell you, I
Yes.
swear to God, you could have the best surgery in a hospital or anywhere, and it's not going to be the best outcome.
Well, San Fernando,
Doc,
they
go ahead.
didn't do anything. Just tell us we had to go back to Mount Hope. When they discharged her for the hand, they really didn't do anything to the foot. Just look at it, and they said, "Well, okay." They give us a letter to go to the health center, and they said, "Well, you have to go back to the Mount Hope, wherever, because they don't do that procedure there and whatnot." So
Yeah,
No.
what they're doing is they're going to be trying to map the circulation to see. You see, as I said, if you just go chopping, you'll have
right,
to chop off the whole. You'll have to cut off the foot. I'm sorry to use the word chop, but you'll have to amputate the foot.
but
So
right,
before you, I mean, as a young doctor, if I'm a consultant in San Fernando and my young doctor cuts that foot, right, he will be seriously reprimanded, right? And
Right.
that is negligence. So what they did was correct. I mean, it might seem callous, but it is correct, because what will happen once you start to cut in a person who has a compromised circulation with peripheral neuropathy, right,
Right.
and a microangiopathy. Well, it's a big word, but if you have atherosclerosis and arteriosclerosis, which is thickening of the arteries, and thrombosis of the blood vessels that supply the toe, it just means that once you start to cut, you have to cut, and before you know it, you have to do an amputation. So in order to
Right.
prevent that, you have to do a picture of the circulation to find out if there's any possibility of bringing circulation from higher up to the lower part of the leg by doing an operation, in addition to cleaning the foot, yes, but if you bring that extra circulation down, then you might be able to save the foot. And that is what Mount Hope has to do, because they would have the ability to do that angiogram or angiography, right, to actually check the blood vessel supply. So the other problem here is not just, you see, when you do a discharge summary in a center of excellence, right, and the doctor says, I give you a letter to go to Mount Hope, you know what they do at the discharge center? Somebody, a clerk, would pick up the phone and they will make an appointment, or they will talk to somebody in Mount Hope, and they will say, okay, this is a patient that has been referred by Dr. X and he needs to see Dr. Y. And before you leave that hospital, or even within a couple of days, you'll get an email, all right, or a phone call that says, okay, you have been scheduled to meet with so-and-so. That is the standard of care that has to be offered. That is not offered by a government buying equipment and building a new hospital and opening Kuva and what, you know. That is something that the government, right, and I'm hoping that this government understands that this is quality care that you can offer. This is what makes the difference. And this is why a patient will come into a private office and meet somebody like us, and we will talk to them and explain them. And if I have to send them another doctor, I'll pick up the phone and have my secretary call that doctor and make sure that they get an appointment before they leave the office. That is what has to happen at hospitals for this kind of care. Do you understand that?
Doc, I have a question. Do you feel that that patient got the proper aftercare after the surgery? Because the foot,
Well,
the
I
leg
don't
time-
know. I haven't. I mean, as I said, all I saw was pictures, so I wouldn't really know.
Yeah,
But
yeah.
from
I'm
what-
just saying,
what
maybe
they-
Farida can give us a little
Yeah,
update on that.
what Farida is saying there is that she went to the health center. So as I just explained to you, proper care is I do, between you and me, right? Almost every 2 days I get requests from attorneys, right, to review medical records, right, with respect to negligence or adverse events in hospitals based on my new forensic medicine hat that I'm wearing, a medical examiner. And I have to now go through the notes and look at what constitutes proper medical care and standard medical care, right? If the patient has been referred from hospital to the health center That's fine, because San Fernando Hospital can't do much again because they need to have the angiogram of the foot. They have to do the angiography to see the circulation. So they have said, you know what, go to Mount Hope. But you see what I'm trying to tell you, the proper care is that you don't just give them a letter and say, go and see it. That's one. Good. Then when they give them the letter to go to the health center, it's not that they go and walk with that health center. The proper care is, and an answer to your question, I don't think is it's not proper care to just give somebody a letter and send them to a health center, right? And when they go to the health center would not understand exactly what happens, because if you see some of the letters that are sent to the health center, right, there's something called a discharge summary, right? And a lot of the negligence lawsuits that the RHAs lose is the actual documentation of the physicians on those medical records where they do not write. First of all, they don't write legibly, right? So it's very difficult for sometimes another doctor to even read the writing, right? And secondly, when they go to the health center, the actual care that they give, in this case, is just dressing. There's not much else that she really needs right now in the health center for just dressing, counseling, monitoring of her diabetes, monitoring of her comorbidities, sitting down with her. Most of these persons, they are mentally stressed as well. Mental health is very important. Yeah.
Not diabetic.
Well, and that makes it even more correct for what they did. If she's not diabetic, it means that it is definitely a problem with the blood vessels that is causing the gangrene that we saw. And if doctors in San Fernando went to cut that, then they would have caused more problems. So as I said, they did the right thing, right? They sent it to Mount Hope. They'll have to do the angiogram. And if they see that there's a circulation problem with a blockage higher up, which is basically what is probably happening here, then they will have to do what is called a bypass and actually bring blood vessels lower down to supply the foot. When that circulation, if that is done at any time, gets better, well then fine, you might be able to save further loss. You wouldn't be able to save the black toe that is there, but you would be able to save more what we call proximal loss above. What I saw in the foot is some signs of infection. Now, that is the problem. You see, because once the dry gangrene becomes wet, so to speak, it means that there is infection actually somewhere, right, in the area. And once that infection spreads in dead tissues with the moisture, all right, it is going to cause more loss of good tissue on the side of the tissues that have been affected by the actual circulation itself. All right. So for me to say proper or improper, obviously, I'll have to sit down and look at the whole thing. But in my opinion, I would clearly say that no, I don't think it was the best care that you could get.
Remember, it's Mount Hope who did the surgery before they went to San Fernando.
Sorry?
Right? I'm looking at when they did the surgery at Mount Hope, right?
Yes.
And, because before she went to San Fernando, is that aftercare and directive? I'm just kind of concerned because the foot deep started getting worse, deteriorating after the surgery, started getting worse. The whole, so that's what I understand. They ended up going to San Fernando over the holidays because the discharger, I think, seemed to be getting bad with the hand. Putting the IV under the skin and not paying it. It seems that the lady never got any proper attention in the emergency room there.
Oh.
That's why that IV situation was supposed to get bad. If they had picked up on it much earlier by paying attention to her, it might not have gotten so bad.
That week there with her in the hospital was the worst I ever been through.
That's in San Fernando or Mount Hope?
No, Mount Hope. San Fernando is just wait. They were good with her hands and stuff. Really,
Yeah.
I have no complaints with that. They were really, really good. I mean, the emergency was nice. I mean, you have to wait, which I accept.
Right.
But like what was my brother and I, we went, so we take turns. Like if I had to take her to the bathroom, Mount Hope, it was totally different. They have my mother sitting there from Monday night till
yes, I remember
Thursday
you told
morning.
me they're waiting for a bed on the chair. Well, that is a problem.
And
that is a problem. Listen,
she cannot walk. She couldn't even go to the bathroom. I had to go Wednesday. I said, look at her hand. I'm begging the nurses at the desk. Did one just get up and peep? Oh, that is okay. That's okay. And they haven't done anything. They haven't given her a pill, a painkiller, nothing.
That is a problem. And I mean, there are two doctors I see on the chat, and maybe they can come in here. But as I said, I am actually. I'm telling you all. I
actually cry when I see my mother.
Yeah,
I
I worked as a medical director at San Fernando Hospital for about 3 years and 2 years. And one of the biggest problem we have is that if a person is placed in a chair, we had a lot of problems with long waiting times, not just to get to a bed, because that's a big problem when you have like viruses and gastroenteritis and all this sort of thing, where you have a big problem for beds and people are forced. And I know that Mount Hope, Eric Williams, I mean, I worked there for a while. My son worked there as well. We had people, and currently there are problems where people wait long times to get to a ward. What is the accreditation standard is, if you place somebody in an area in hospital, and that's the accreditation standard, but that patient should be afforded the same level of care that they should access in any area of which they are supposed to get specialized care. What I'm trying to say is that she should have been treated even though she was in a chair. So even if you put them in a room, right, the accreditation standard, and I'm talking standards and whatever, but real humanitarian thing is you don't leave people sitting in a chair with a serious problem to the foot and not have somebody attend to them, right? And sometimes it's not, sometimes it's not so much doing anything, because you can't really do anything. Think about it logically, right? You have an infected foot, right? It already has a cut. Right, the prognosis is poor, and I'm not telling you this because I want to make you dejected or anything. When you look at the patient and you look at the foot, right, there is a high probability that she will lose that foot. Right. The problem here is that I'm being quite frank with you. I'm not trying to hide something with you. But the thing is that there's so much that you can do in a chair, right? And therefore, she should have had a bed, and that is proper. But I want to say something. Don't get me wrong. Don't get vexed with me. But I have been in Canada. I go there regularly, right? I do some work there sometimes in the hospitals there, right? And when I go there, there are people who sit in chairs, right, waiting for beds, right? They do not have beds, right? They have the same problem. There are a lot of lawsuits right now with people sitting on in chairs and getting heart attacks, much the same as you have in Trinidad and Tobago, right? So the thing is, it's not something that happens here because of a lack of care. It's just that the whole system, right, where the bed availability is a problem, maybe not so much doctors, but what I don't like is that even if somebody is in an area of care, they must be afforded, right, the care that they should get. A doctor should see them, right? Somebody should open the wound, they should assess the wound, they should say, well, look, this needs a debridement. They could keep them nil orally, right? Book them into the theater, so that, in other words, you don't just leave them there and then
I understand. Or even get a relative to come and assist, because they are overwhelmed with people there.
And have the
they
relatives
just want, because to take them to the bathroom. I mean, they have a lot of work, but
I agree with you fully, and in answer to the question, that obviously is where I'm trying to say those are the things that make the difference. Care. That's the quality care, because you see what you are complaining of is not that the fact that the foot itself is going to be lost. It's not the fact that they didn't do an operation, they did it. It's not the fact that they didn't do the angiogram. What you are talking about there is the level of humanitarian care that has to be offered to your relative, and in a time when she needed more attention and more support, and that
because she couldn't go to the bathroom. She had to beg and cry. And
but maybe the other two doctors could weigh in a bit here. All right. I mean, I don't want to kind of, talk too much. I mean,
in my opinion, Doc, in my opinion, I think that the foot wasn't properly taken care of with the length of time to get the treatment. After the surgery, I don't think the proper follow-up care was done and the proper directive there. But we all know that it's not understaffed, right?
Yeah.
We're not properly staffed, and relatives definitely should be allowed. That would help the staff if relatives are able to stay with the patient and clean them, and that would make it easier. We already understaffed.
Because who is doing it? Who is doing the dressing at home? Isn't the relatives doing it?
Yeah, I am the one who is doing it.
So, the thing about it is you're trying to say, don't come in an area where the lady is there alone with nothing happening. And then when you go home, it's yourself doing the dressing. This is
something needs to be addressed too.
She's there sitting from the Monday. Nobody clean her or assist her. She has to be, some doctors, nurses were really nice. The male nurse had to take her to the washroom. I mean, if like a relative there, that's a big help.
Yes. No,
I
no,
had
no.
to beg. I had to beg one on the
I agree
floor.
with you fully. I am
So
in terms of
this kind of thing have to change. By the hook and the crook, this have to change. Doc, we ain't
No.
taking this.
Maybe I mean I would like to hear the other doctor's perspective. I mean the thing is that
Yeah, Fazia, Dr. Parum, jump in.
Well, well, here, good night to all. Good night to TNT. Lovely country. Here we treat a diabetic patient or patient with these type of problems with excuse my English, priority, you say, no? Priority. Yes. And I have to see the patient myself to give a proper evaluation, right? To give a proper evaluation. We use a lot of different type of medication. We have different procedures to save the foot of the patient, diabetic patient and no diabetic patients. No, we have a lot of experience in this. But to give my full evaluation on it, I need to see the patient myself, because not all patients are the same. Now, as you say, my colleague there, doctors, all patients can be attended. Even sitting on a chair can be attended, not waiting 3-4 hours. I find that is not proper or humanitarian way. Now, what is Dr. Ramrup, no? Dr. Ramrup was describing, when you have this type of patient, they have a psychological impact, right? A very strong psychological impact. You have to sit down, speak with them, have time to care for the patient. Because I have a patient with worse condition, diabetic patient with walnut 3 going to walnut 4. You speak to them. Just simple speaking to them helps them a lot. You guide them a lot. The family as well, you guide. No? And it is reversible. And I have a lot of evidence that where we use oxygen therapy, we use stem cells procedures as well to help bring back circulation, improving circulation in the patient, right? The most important thing is for this type of patient is the diet, the diet that you put on them. You cannot just give them treatment and say go home like that without orientando, guiding them in a proper way. Okay. There are a lot of medical staff that are not experienced in this type of or in diabetes patient, pies diabético, we say in Spanish, diabetic foot. Is it correct? I say it's
Yes.
not. Okay, and there is not a lot of experience in this type of wounds. So this is where we get the iatrogenia. I don't know how you say in English. Iatrogenia means oh yes, negligent, a little negligence, medical negligence, right? So dressing the foot at home is not indicated. That has to be done by the doctor, the specialist in this way, or the nurse who is well trained in that area. Okay, but I imagine that you had no choice to do the dressing at home yourself, right?
Yeah.
Right.
'Cause I don't
So
want
I have to see the patient to give you a proper recommendation, evaluate the patient myself, right? But that does not happen here. Yes, sometimes we have so much patient that they sit down in chairs, wait 2-3 hours for attending, but not 2-3 days. No, that is impossible, right?
Exactly.
Impossible.
without cleaning and going to the bathroom. She's scared to
Yeah.
even start to
Terrible.
drink it, And
Okay.
I cried. I really cried because I said, you know what? I'm gonna take my mom out. I prefer she come home and stay with us. And if she has to die, I mean, I accept the fact already, but not in that condition. Yeah.
Oh, I agree. That's not right.
You're denying the relative to come in there. You're not taking care of the patient. You're acting like a bulldog in the hospital. But this is the PNM culture for years. This is what they allowed to get away with for years.
That's
Right?
how
And this is the status quo that they want to maintain. And this is why they're trying to disrupt Mrs. Bisesa on opening the Cuba Hospital and making any advancement. They're going to give trouble. They already demonstrated they're going to give trouble. And we have to override them. We have to rule with an iron fist over these people.
You know what I noticed in there? The place is disgusting. You know, stink. Even one of the area my mom was in had bedpan with poop. And they don't bother. They leave it right there in front with all the patient. And they just put it in a corner and cover it and leave it.
That was in the
And-
emergency department or on the ward?
Yes,
The ED?
emergency. And another thing, it's not the washroom. Some of it, like one or two that I went to, was wheelchair accessible, but the rest, no.
None.
But San Fernando was excellent, you know, for wheelchair accessibility. But
But the years of
Mount
arrogance
does-
under Diaz Singh and Raul Lee, I mean, you can see that kind of contagious behavior went right through everybody. It was very catching. So
doors, it have no
Yeah,
door.
these. Listen,
Uh,
I keep
no-
saying these are the important things that need to be rectified in our healthcare system, in the public healthcare system. It's not just the infrastructure. It is really, well, I mean, of course, having your washrooms clean and thing is not so much infrastructure. It's more of a systems approach, right, to the people who actually have to make the healthcare as quality healthcare as possible, the best quality of healthcare that we would have. And the problem so much is not just building hospitals. I would think and I would hope that our current ministers understand that yes, you have to maintain your hospital. Yes, you have to have scheduled and random maintenance, and you have to have a program. Spend more money, right, in correcting these problems. For example, you talk about a policy where your relatives are not allowed in a hospital, right, to assist in the care. Now, that policy could only be implemented if you don't have a person we call a patient care assistant. A patient care assistant is a lower level and a sort of nursing assistant, lower than a nursing assistant in terms of training, where that patient care assistant would be assigned to a patient, even if they're put in a room. And that PCA would change the shift and they will go with this patient to the washroom. They would sit down with them. They would help them, give them something to drink. They would talk with them. They will wheel them to the X-ray. They would take them to the washroom. Right now, if you don't have patient care assistants in your system, or you don't have enough, then of course you need to call your relatives. So these little policies, Gary and guys, I think these are some of the things that they really have to look down. Now, so what you have,
we have to point it out. So we have to raise the consciousness about this. Send that clear message. That we are paying attention. This is what we want to address, because I don't care how much staff you have. It's always good. The more help you have in a hospital is the better. So allowing the relative to spend time with that patient, it also helps to keep tabs on things, and you can help also. So
right.
This is something we need to fix.
I don't know if anybody, see it's Fazia, right? Dr. Fazia. I don't know, you want to say something? I don't know if you want to add anything, because I saw you made a very good comment about the accreditation process. I remember when I was the medical director at San Fernando, the Joint Accreditation Council of the JCO, they came to Trinidad, and the International Accreditor Council, and we worked with the ministry. The ministry drove that. I was at the time, Southwest was the pilot, right? What we did is we went through the process, and there's a book that I have in my library here, good, which when I was medical director, that book was published by the ministry, and it is the National Accreditation Standards for Trinidad and Tobago. The problem is that I remember going to a number of interviews for the job of medical director, executive medical director, CEO, and I would walk with this booklet, and I would say, when they ask me normally a question they ask in the interview is, what would you do to improve the healthcare system in San Fernando, or Eastern or North Central, Port of Spain? They even went to Tobago for that interview in the last 10 years. And I would pick up the book, and I would show them. And I say, well, one of the first things we will try to do is that we improve the quality of care based on standards of care. Because when you look at what is happening, one of the ways that we we have to recommend to the attorneys when they send these cases to me for negligence or for hospital to pay these patients is that once the standard of care is below the standard that is required of care, right, that constitutes negligence. All right. But the negligence laws in Trinidad, right, are not the same as the negligence laws in America or Canada. Each country has different, negligence laws. So in Trinidad and Tobago, our negligence laws needs to be rectified.
It needs to be revamped. Yeah.
It needs to be revamped. And what happened is that our Honorable Prime Minister, as an attorney, as senior counsel, has identified that. And she has said that what she hopes to do is to have the public get access to some department where they are able, and they even wanted to bring forensic people from abroad, but as I said, you don't need that because we have people like us, and I know another couple of doctors went across to the University of Florida, and they are actually in the course in forensic medicine, and I'm hoping that they come back to work in Trinidad because these are the kind of persons who we would need, right, in the Department of Forensic Medicine in Trinidad, if we are to change around a few things with respect to these little accreditation standards. Now, it's we have a good discussion today because we have an actual patient with actual problems, and you become very passionate when you hear this as people who are not doctors, so to speak, because we hear this every day. We see what is happening. Sometimes we become almost callous because, when we look at the foot, and as a surgeon, I would say, "Oh my God, it's okay. It just needs to have an angiogram, and we need to probably leave the foot as it is." But to us, that is ingrained in our system. But what really is the difference is that we really have to explain that to the relatives in a way that it is easy for them to understand, and for them to feel that there is some caring there, right? Because sometimes it becomes so routine to us that we have to make sure that we appear to be caring. Now, because you see it every day and it's not your own family or your own relative, sometimes you don't personalize it, you see. So you must have the backup persons, the quality managers, the social workers, the nursing people who are doing the discharge summary. And you must have embedded in the health sector, right, the institutional capacity that even if there's very little people working, that level and that standards operate right through, so that things like having a washroom that is not cleaned, that having a bedpan that has stools in it that is not emptied, right? Having washrooms in a hospital that is not user friendly for persons that have the disabilities and the handicapped, and having bars and sidebar in a hospital. I'm not talking about a public washroom downstairs in the lobby. I'm talking about washrooms within the hospital. You see, so these are things that it's not just the doctors and nurses, right? It's not just it's the other technical heads that I talked about that sit at the meeting with the CEO, the people who are in charge of the infrastructure maintenance, the engineers who are building the infrastructure to support the patients, right? If a patient, the biggest problem we have in hospitals is patients falling. One of the biggest problems we have with lawsuits is people having a heart attack who left in a room and not being seen before the doctor. They get a heart attack in the room. You understand? So what needs to be done really is to find a tool, right? A tool that is actually implemented in all the RHAs that allows all of the relevant sections or services to understand that there's a whole of hospital, whole of health sector management where there's 7 domains that we talk about, right? And I won't go into it here. But what it is that each one of those persons have to make sure they do their job properly, right? In accordance with international accepted standards. It's not just the doctors and the nurses. There are other things there because you have to have people who bed manage. Good. There must be people.
Correct.
There must be people who triage patients who are more susceptible to having just 1 hour or 4 hours of decreased circulation. Circulation is a nasty thing, and if you don't have proper circulation to a foot in a person who is sitting down, it's better you send that person home and tell them elevate the foot, and when you have a space, you bring them back in, because just having that foot hanging down there swelling with a lack of circulation means that you're doing more harm.
Yeah.
So as I
Yeah.
said, if I am allowed to do a forensic analysis of this, I can give you a very good negligence report, but I'll have to have all the nurses' notes, because one of the problems where they lose these cases is they don't document. You see?
It's poor
So-
documentation, and that's the problem.
When they don't document, that's where they lose the cases, because
That's
you
a
see
lot, yeah.
what, and then sometimes they come and they fabricate it after. They go and they write a new note and they put it in and they say, oh well, this doctor came here and this nurse came here and this nurse wrote here, and you can see it's fabricated. So we have also forensic persons who do documentation analysis, and a lot of those are thrown out in court because they actually go and fabricate documents and they insert it in the notes, to say, well, they actually were looking at this patient. So
Well,
So-
that's happened with my
Go ahead.
mom when
Yeah.
they did that to her hand and stuff.
yeah,
They tell her that she needs to do it over again because they have no records of it. You
Yeah.
done damaged the woman hand already. What more record you want to have?
They have no record that he knows who did that. You see what I'm saying here now?
Yeah, you
But
see, Gary,
where-
that's the thing. If I may interrupt, that's the thing. You see, there needs to be a system of accountability. There needs to be a quality control department. There needs to be someone who monitors the key performance indicators to measure how we meet our standards of care. That is non-existent in Trinidad. Like
Yeah.
in my
I
one
agree
year
with you.
at Dr. Ramrook, I'm not a physician.
Yeah.
I have been a nurse manager for many years, and I was the previous nursing director at West Shore.
Yeah.
And I had just done that just for a year. And when I had thought that being in the a private healthcare setting would be a bit, a step up to, working in the public sector. But what I found out, sadly so, was there was a mentality of a don't care, like a don't
Yes.
care mentality.
That's true.
Right. And this, whether they don't have pride in their work, whether they just really don't care, it just seems every single person I interacted with they didn't care about their patient. They didn't care about what's happening. They couldn't be bothered. They were coming in for a day's work and they left. Right. And that mindset has to change, because if you don't care about what you do, then you don't care how you do it.
and
Right?
there's a
And that
method.
transcends, that
there's a-
shows in patients' care. Like we've had patients, I mean, it is like I am in Canada right now. We do have people waiting in our ICU, in our emergency, 12 hours, 24 hours, but they still get care. They're
Correct.
not neglected.
Even they,
Because
even
you
they in a
have to
little
look
room.
after them.
Yes, even if they're in a
And you have a
little room, yeah.
manager, you have
Correct.
a quality
Yeah.
care controller who actually comes and makes sure and checks that you are doing
Yeah.
your job.
Correct.
And if you made a mistake and put an IV in the wrong place and the patient's tissue became, damaged, there is an incident reporting system that has to be reported, followed up, and actions taken. So you would know which nurse did this or whoever did it, and they will be held, accountable for it. And plus, it's a learning part of it too, right? So to say that they don't know who the nurse was, who hurt your mom's hand or whatever it was, that's just very lame, because it should be a record of everything that was done, who did it, when it was done, etc. That
That is-
system doesn't exist, right? There's no accountability, no responsibility. No one cares to do that. So this entire system has to change. The mindset has to change, because this don't care attitude would not get us anywhere. We can
They
have
have
the best systems, the best structures, the best policies, and if I don't care, nothing would be done better. Nothing will be done differently.
They
Yeah.
actually
Yeah, that
the procedure has to be they has to redo it because they have no report on that. And
That is unacceptable. That is unacceptable. Yeah.
Yeah. you
okay.
see,
One of the things
have
that
no
I
report
observe, one of the things here, what we do here, to avoid all of these things, we have to have selected people who are very. When a person does not care in health center, that shows he has no good training. A well-trained doctor or well-trained nurse cares about his or her patient. There's commitment, right? There's a lot of commitment. Now, we have also implemented that no relative is in some hospitals here. Only one relative can see the patient at a certain time. Only one. Why? There are persons who uses the patient's bathroom who accompanies the patient and do vandalism, right? It is to avoid vandalism. So this is why you have certain restrictions, but not all is indicated. Not all the restriction is necessary. Is the word I'm saying? I meant not necessary, but yet it is necessary, right?
All right. Yeah, go ahead.
So, Dr. Ramroop, you said we do have an accreditation
Yes, we have a
process in Trinidad.
We have an accreditation process, and
This is the first time I'm hearing about this. I'm quite surprised we actually have one, because I've never heard about it.
We do. Trust me, we do, and I was part of that process. So what happened is that let me give you an example. And now, if you asked a very important question, and I said I do some work in Canada, right? And I am very accustomed. I know what is the difference. I actually walk the talk sometimes with respect to this. So what happened, right, is that you ask a question about why they don't care, and it almost seems as something generic or genetic, in the nature of the persons who provide the care, right? Let me give you an example of the solution to the problem and why it is in Trinidad it has evolved into this. When you go to the airport to check in, right, to go on a plane in almost any country of the world right now, okay, you have to check in by the airline, and then you go into the security line. You go through a process where you have to take off almost everything and go through the scanners, and then you go on the other side, okay? And that is now a global standard, right? Now, there obviously are people who actually break this. I don't know, you hear people getting into the plane where they shouldn't and whatnot. So there are obviously breaches, although it seems to be very sanitized. But you understand what I'm talking about. In some countries like the US is even more stringent than other countries, the Caribbean and whatever. But there is a process, right? There is a system. So that when you are working the system, either as the provider or as the traveler, right, you fit into that system almost automatically. So it avoids as much errors and adverse events as possible. Do you agree with that?
So because you know your role.
Right. So in other words, then you actually fit into a working system.
Yeah.
So that even if you might have bad habits, you have no choice, because as Dr. Moran said, you have the controls, right? You have the quality controls, you have the supervisors,
you have the quality controls,
and whatever. Right?
That's what it is. Yes.
I made the point a couple of days ago where Trinidad and Tobago has a quality standards system, but is the ministry evaluating the quality of the ministry rather than an independent quality. So
that cannot work,
right? So that is the problem. So that's one. Now, in the Eastern Regional Health Authority, right, when we looked at all the awards that were given to quality or whatever, although it's internal, they came to the University of Trinidad and Tobago. And what I did at the time, as I'm trained in providing what we call a course called Enterprise Risk Management in Healthcare and Root Cause Analysis, right? Risk management. So the tool that has been used by big healthcare organizations like Kaiser Permanente and all of these big private organizations around the world, you read about it in your journals of healthcare management, which are obviously, I did my MBA in healthcare management, so I have the network of healthcare journals and peer-reviewed articles, and I keep up to date with my healthcare management, contemporary empirical studies, and what is happening all over the world. So the tool that has to be used in Trinidad is something called Enterprise Risk Management in Healthcare. We did that with the Eastern Regional Health Authority. Good. And of course, the quality managers become now quality risk managers. So in other words, then what it is that all the different 7 domains, from finance to operations to the service lines to clinical, all the 7 domains of the healthcare system, whether it be tertiary, secondary, or primary care, they must now put into these into their systems. They need to map the systems. They need to remove duplication. They need to look at the processes, right? They need to streamline the processes, no redundancy, whatever. They need to measure them. They need to actually evaluate them, put in the key performance indicators. They need to measure these risk indicators, and the quality managers or the quality control officers become almost quality risk managers. They report back to the CEO, right? So what happens is that using this tool, Eastern Regional Health Authority, right, began to use the accreditation standards right? And they actually began having better quality healthcare outcomes, right, than the other RHAs. And that was under the CEO who passed recently. He was a good friend of mine's. All right, he used to do a lot of emergency work when the UNC was in power, the last time around. And then when PNM came, they put him back as CEO in the Eastern Regional Health Authority. I think it was Soyafat, right, Ronald, right, and he passed recently. But he was a good guy, and he actually hired UTT, and I am one of the course developers at UTT. So we developed the enterprise risk management course for Trinidad, and we did it with Eastern. It ran over about a month, and they did it virtually as well as physically. So there is a tool that we can use, and therefore what it does, all this, like the person who's supposed to clean that toilet she talked about, the person who's supposed to empty the bed pan, right? The discharge summary, the discharge process, to go to the other hospital.
The internet service is pretty bad. It's cutting
Listen,
off.
as I said, I do right now, I have about 4 notes on my desk. Recently, I had another one with the same process. And the biggest problem that people lose money, the RHs are paying out in this country right now, is because they have lack of documentation, poor discharge process, and something called the consent form, right? The fact that this person would have had a consent form, right? The consent form, they bring it to the patients. They tell the patient, just sign this for me, please, right? And when you go to a hospital, Gary, good? A hospital is a specialist treatment center. In other words, then a hospital is where you go to get specialist care, right?
Yes.
You go to Trinidad hospitals, what happens a lot of time, you see junior house officers, right? They do almost everything, right? And they will call, sometimes they don't even call the specialists. The specialists are in their homes or in their private offices. They leave hospital around 9, 10 o'clock in the morning, and then they're not in the hospital. So when you go to a hospital, most of the day as an emergency, you don't get specialist care. I worked at in Miami, right, at Jackson Memorial, right, when I was the head of emergency department at San Fernando. And when I went to Jackson Memorial, I fit into the same process that we did when you go to check out to go into an airline. That I fit into a process, and I had to follow everything. Right? I mean, you're talking about bed management, documentation of care, robots in the lobby. I mean, you talk about a level of care that was fantastic because they had their accreditation system.
Everything is computerized. Everything is documented, right?
So the thing about it is that really and truly, the enterprise risk management in healthcare and root cause analysis is a tool that can be used using the documents like the accreditation standard I mentioned the other day, the common procedural terminology, where we use all the CPT codes that for all the processes that you do, everything from cleaning a foot on the ward to an appendectomy, to doing an incision and drainage in the side room, removing a ganglion, everything has proper codes, right? So that when you come back to now look at if there's a problem with an adverse event, it will be all recorded. Now, how does that affect our patient? And I think right now, I mean, we have to understand that if this is not done in the hospital, you could spend millions of dollars in opening a burns unit. You can spend millions of dollars in trying to open the Cuba hospital. But if you do not address these sort of basic principles of quality healthcare, you will not get an improvement after 5 years. You will have the same khaki pants at the end of 5 years. People will be disgusted because the real treatment here is what is happening in this discussion today, right? This patient has sustained an adverse event because she was allowed to stay too long, right, in a room. The thing about it is, I won't say bad, the good or bad, but what it is the hospital cannot prove that it could not have caused her condition to get worse because they don't have the documentation to show that during the period that she was there, right, that she received any form of care documented. And when they go to court now and they say, where was the notes, and they say they lost the notes or they can't find the notes, that also will cause them to lose the case. I'm just saying, I'm not taking the case, but I'm telling you, that is because they had no documentation to support the fact that they were affording any care to that patient. So that when the claimant lawyer goes to say, well, this lady lost her foot or is losing or got worse because you all caused her to sit in that room, the RHA cannot say anything in court to justify that, because there's no documentation that a doctor or a specialist, remember I told you, when you go to a hospital, you are supposed to receive specialist care. Dr. Maharaj spoke about that. So it means that if you did not see a qualified specialist registered with the Medical Board of Trinidad and Tobago, right, in a specialist, and he came in and he opened that foot in that room where they had her for a couple of days or many hours, then they'll lose the case. Now, it's not about losing the case. It sounds callous that you're talking about case. Case is a patient. And I'm not trying to say that the patient is a case. What I'm trying to say is, if it comes to that, right, clearly there's negligence. All right. So if
I know, Doc, I see negligence. In my opinion, I think there's negligence from the time she got the treatment, the surgery, and everything else.
Yeah. Well, as I said, the surgery, since I haven't seen what were the indications, I haven't seen the actual angiogram showing the block. If there was a block and they picked up that there was thrombosis to one of the arteries supplying the foot, and they did the amputation and they did surgery, then it would have been procedurally okay. The problem here now is the aftercare, right? And the fact that even if you did remove a piece of the toe or most of the toe or some of the foot, that if you want to prevent further loss, the aftercare is even more important than the initial care, right? So it's not just about cutting out and saying, go home and get it dressed and come back when you have a problem. It's about what I talked about in the beginning. The whole process must be documented. There must be counseling, and you can't have people waiting in a room for long periods, especially in this type of patient.
3 days in the emergency room on a wheelchair. None of us could sit up for 3 days in a chair in a good, healthy condition. We can't do that. That's stressful.
That is not good. That is not. There are other processes with other systems that can be put in place. I mean, if people are waiting longer than a certain time, there are other what we call spill-off wards or like wards that are unoccupied. For example, in the night, all your outpatient clinics are closed. Right? I remember when I was in San Fernando as the medical director. Whenever they had overcrowding, right? Imagine next door to the emergency room, there were like 15 outpatient clinics that were empty. So that what you do is and there were cuts in them, yes? So what you do is you remove the patients, and instead of having them sit down in the casualty, we would send them into those closed clinics in the night, right? And have them on beds with patient care assistants taking care of them, the dietitian sending down food to them, right? And of course, we had relatives staying with them. So, I mean, the thing is, remember I talked about, it is not just about the doctor and the nurse and the casualty. It's about all those domains have to work together. And if let us say you have a private, let us say Mount Hope casualty, right, was run privately, like what what Fazia was saying, right? And that was a private, and let us say the RHA, North Central, right, contracted that to a private provider, right, to manage that casualty department, right, in Mount Hope, where your relatives stayed for 3 days. Do you think, let us say they're making money out of this, right? Do you think that would have happened? The answer would be no. You know why? Because they would have had every single of those 7 people that I talked about, they would have had to do their part. And if they didn't do their part, they would have been fired.
Yes.
Right?
That is right.
So the whole thing is that Dr. Bodo and Dr. Rishi would have to really sit down carefully. And I had written something on Facebook not too long before the elections, and I said there is a possibility that the government have to look, especially right now, in terms of if you want a fast improvement of quality in key areas, they should really look at privatizing the emergency healthcare system in Trinidad and Tobago. That is pre-hospital care, which is already privatized to a bit by private ambulances, but the whole emergency care in all the emergency departments of Trinidad and Tobago. I think that if they
there has to be some training. There has to be some training and preparation, so and advisors like yourself.
I think that even if we do it right now, because of what you saw with the Nursing Association and Cuba Hospital, I don't think that in 5 years our government will be able to get all aspects of the team right in alignment, and that is and to get the system like the system that operates when you go to leave a country and go to the plane to go through the airport, where you go into a system that works well. Understand what I'm trying to conceptualize? What I'm trying to say.
Yes, exactly.
If you go into a system, that system works since 911, and that system removes as much adverse events as possible, right? What I'm saying is that if you don't get your hospital system to work like that, right, and you have already in the first 5 years, you just the first couple of days, one key, and I started off by saying the nurses are very key. If a nurse in a hospital blocks your tail, you're not getting anything done. The nurses are the most important element of healthcare delivery in the world.
Yes.
Good? And if you don't have the support of the nurses, crapo, smoke your pipe. Okay? So the trick is, and I give you the example of what happened to me when all of them walked out, right? So what is the tool I asked you to, what I kind of told you, the tool I use? I use evidence-based, supported by data, right? So they couldn't buff me up, because when they came to the table, I said, no, hold on. Let me open my diary for you. Let me show you. On the 12th of so and so and so, the following people attended this meeting. The meeting was so and so and so. These were the items discussed, and this person said this, and this person said that. Within a month, they will put it in, right? So the trick about it is now you have to train your managers, and this is the kind of thing I'm telling you, that the training that you have to give the new ministers when they go into the different ministries to deal with those people who are going to give them blocks, right? They have to have their book, right? They have to have their documents, so that when they sit down now about a week or two after, and they say, excuse me, we were at a meeting and so, I just want to go back and you told me this, you know what I mean? Now, this is what they have to do, unfortunately, because you are now saying that what Fazia is saying, what Dr. Maraj is saying, what our patient's relative is saying here today. Farida, if you don't, Farida left, but if you don't have that system that operates in the airport, then we have to start that, and to institutionalize. You have to do what's called institutional strengthening, right? If you don't institutionally strengthen the healthcare system, public and private, in this country, we will remain in 5 years' time with the same problem that we have, right, with this patient, with Farida's mom, because you're not going to get that smooth operation like when you're going to leave to get into a plane. Right, and that is where the problem is.
But it's making the government liable also, because remember, we put in certain things in place too.
Well, I sent an article on the chat showing you there is a lawsuit against the Southwest, right? And I said in that when I put it in the chat, I said we need to help our ministers to mitigate where the little child was. I mean, I was part of that case. Yeah, the attorneys were Rup Narayan. Right, and they brought the case to me, and I did the forensic analysis of the case, and the RHA has to pay, right? So the thing about it is that we know, right, what is happening, and we have to. There's a tool that is used. So the trick now is that the ministers will go in there, and they're going to get bamboozled. There's a guy. I mean, I don't want to call names, but there's a certain guy who was in my every single interview that I attended. Right, in this whole from Northwest, Southwest, whatever, he comes from the ministry, right? And you wouldn't believe that guy is going to be talking to them there, and he's going to be giving them advice on what is the best thing to do, right? And 9 times out of 10, he's going to convince them that what he's saying is the best thing. You mark my words. Yeah, and they're going to keep him,
Okay, I mean, the ministers, they're going to keep the guy for the advice.
That same guy. Because I tell you, boy, as I say, I get wrapped up in it when I was working in ODPM and I was in national security. The guys will come and they will talk to you, and they will make you feel that they're your friends, and they will make you feel that they are supporting you, and they will make you feel that they know everything, and there is nothing wrong. It's almost as at the end of the meeting, you feel, oh my God, why didn't it was so good? It's really, really good. And when you come out of the meeting, then you'll get back to reality and say, if it was so damn good, why it is one? I went back the election. We win the election because it definitely wasn't good. You know what I mean? So we have to be careful.
Yeah, but I mean, listen, we went into this election with the premise of upgrading the quality of care, the service delivery, basically. And this is what both of us, all of us inside and outside the country, a lot of us are staying outside the country because of the simple things like these things there, between that and the crime, right? I mean, you cannot come to Trinidad and get a proper healthcare. And seeing these things, and this, I mean, there's so many. The numbers are very large with the incidents, you know, of negligence and arrogance. So I mean, this has to end. I mean,
Yes.
I am intent to put up the biggest fight alongside the Prime Minister on upgrading this thing, because I have no tolerance for this. And we're going to bring all the experts here to advise. Whether they take it or not, we are going to advise, you know, privately and publicly. You know,
Gary, Dr. Amrup, you was mentioning before, no, about the nurses walked out on you there. Now, nursing system is a sisterhood. It's like the Freemason, right? I look at it as that way. Now, that was clearly show sabotage in all way. That is where there has to be legal action taken against them, right? These type of people cannot be in the health system. Whether you're a senior nurse or whatever, you have to be fired, right? When you put in place and jeopardize the health system, here in Venezuela, you can be whoever you are, how trained you are. You try to sabotage, you get yourself in prison, right? We cannot have people in the health system or any system that is against the responsibility of the government, right? If there is a good project and you go against it, you are committing a crime, right? Whether or not, let's say Patrick, let's say Rowley made up a very good plan or project in which we know he didn't do, no? And the UNC cannot say it close it down because Rowley made it. You understand? They have to continue. But this project with the hospitals, it was closed down by the PNM government, and in certain, and they managed to have this type of culture that not to care for patients, not to care for their own people. Now, the nurses, what I see in Trinidad, they are nurses to pack, they are nurses to clean, they are nurses to do everything. That is, for me, is not work for a nurse. A nurse has to be trained in the medical field only. All nurses have to know how to put an IV, how to make treatment, is the assistant of the doctors, and give priority and identify urgency and emergency, right? So the nurses has to be trained completely. Now, someone was mentioning today, I cannot remember that what was it, but the system here in training nurses in all hospitals has to have a university of the nurses, or the medical university in all hospitals here in Venezuela has it, to train doctors and nurses, not only to go to directly to the university. You understand what I'm saying, no? Right? Yeah. They don't have to go directly to UWI because the traffic and the timing, it is very, how you say the word, ocupa mucho tiempo, occupy a lot of time in traveling.
Time consuming.
Time consuming.
I've seen training academy with hospitals here in the US too.
Yes. Now we train the doctors here and nurses here directly. Yes, you go to your 6 years, 7 years in the university and hospital at the same time. But when your real training is in the hospital directly, and you are certified for it. Now this culture, we have to take it off immediately. And I strongly recommend, we cannot be afraid of taking off position, not getting rid of people, no, relieving these people who are sabotaging the system of improvement. Dr. Amrup, I feel very hurt to hear that what happened to you with these nurses. As you said, they did not have cellular phone, they did not have anything. I feel very hurt to hear that happen to you, you know. But that have never happened to me here. I never heard that happened there. Now, I'm speaking now, and I feel it in my chest, you know, and that cannot be permitted. It is like a Solia. You say to a Solia or a Polydor.
It's the party group thing, man. It's the party
Yes,
group. You know,
yes.
it's the
Yes.
PNM party group thing. Let me
Yes.
tell you, they're planning to undermine us as we go in there. We know that.
It's gonna
Yes.
it started already. It
You
started
see-
already. Listen, I mean, I'm not. You know, Parum. It's Parum, Parum, right?
Yes. Yes.
So is it Parum?
Parum.
In Venezuela.
Parum. Parum.
Good. So it just didn't happen there alone, and that I mean is I don't know where this program is airing right now, if it's going public or people can actually go on YouTube and see it or it's shared. But
Yeah, this is live on YouTube right now.
what I mean, so we have to be. Although I have to work with these people, so we have to be politically correct, to be careful. But what it is that they are good people in the system, right?
Yeah.
And
Very good.
there are certain people who have influenced, like if you look back at Hitler and Napoleon and all of these people, there are certain people who are just influencers, right? They don't need to have AI to influence. Influencers have been there with us since the dawn of man, And so what happened is that we had the same bed management system and the discharge process that I think Fazia was talking about, and I had mentioned earlier, and where we had patients who were discharged by the doctors at 7 o'clock in the morning when they do their rounds, 8 o'clock, right?
Mm-hmm.
And these patients would stay on the ward all day until their relatives come for them at 5 o'clock in the evening visiting time, right? But there were patients downstairs who had heart attacks and who needed the bed, and these people were occupying the bed, right? So when I was medical director, I met with the matron, same khaki pants, I met with them, I sat with them, I explained to them. I got the CEO to identify a ward, an area where we put beds in it, right? So that in the morning when doctor comes, we will move these patients, right, to that ward, and we set up nurses and patient care assistants, and they will get better x-rays, and the doctor, we put doctors, as the medical director, I assigned doctors to that ward. So it was a discharge ward. Good. And they now will go, and it would have freed up beds, right? Because they want to move to a discharge ward, right? Because they're going home, yeah?
Yeah.
So logical, so common sense, right? They blocked it. The nurses rebelled, and they came to the matron and they said, no, that cannot happen, and they have already been doing discharge and it has worked for up 10 years. Listen to me. I have a 70% block in my widower's artery right now, and I think I got about 60% of the block when I worked as medical director in San Fernando Hospital. Because
it's very stressing.
The stress was the mental blocks, right? And I could imagine. I mean, I know Lux from very long. When I was a medical student, he was the medical student in the class above me, and he was OBGYN, and he gave me all his notes, beautifully written notes. I want to tell you, he writes beautiful. And the good thing about Lux, he's a guy who will listen, and he has patience. He would just turn his head and he will listen to them. Unlike me, I will get angry, and I would say, so I'm happy that he's there. And when you come in as a minister, and all of a sudden in the first 2 days, you see the biggest fraternity that you're trying to reach out to, who you need your support when you go to that hospital, because I told you the nurses are everything in a hospital, and they come out right out and say, hey, it is not possible.
No.
I mean, it's going to cause a block, just like me in that casualty and on the ward with the discharge. You see, you understand the pressure, the stress, okay?
Yeah.
But over the years, I had to find a solution, right? And therefore, I went and I did my MBA in healthcare management, because I didn't know what I could have done as a doctor, raising my pressure, right? Also, there must be a way to deal with this, right? In such a way that it mitigates against your heart block. It has to be. And I found out in the MBA that there were. Now, what made it now worse now is when you come back with all this big fancy MBA or whatever it is, and okay, they put now you're trying now, after you finish with your medical directorship because of a change in government, right? And they moved you now as medical director, you sit down there, and then after that now, your own colleagues don't want you around because you're trying to change the system. Good. They don't want you to come in there now and bring in medical things, because if you come in now with MBA now to solve the problem, it means that doctors, senior specialists can't go home after 9 o'clock, 10 o'clock and work in their private practice, right? And leave the hospitals for the junior doctor to run, right? And therefore, one of the metrics that they teach you, one of the key performance indicators they teach you about a hospital, right? And you can judge hospitals' performance, one of that, just one of them, is the percentage of specialist care, right, per patient, right, in a hospital. So, for example, if you have a 700 bed hospital, and you multiply 700 beds by the patient 8 hours of care, right, and you calculate the amount of specialist time for that, you work out a ratio, right, and if that figure is low, it means that you have less specialist care per patient. And that, when you look at the outcomes of that hospital, it definitely is bad, because you have to have more specialist time per patient. So it's a metric that is easily measured, and it works in all of our hospitals in Trinidad and Tobago, I dare say. One of the biggest problems is that you do not have the percentage of specialist care, right, being afforded to the patients while they're in hospital. Good? So this is what I'm talking about. So you get blocks, not just from the nurses, but you're going to get blocks from the right? And the reason for that now is they say, oh my God, so what can I do? So the trick now is, when we look at the journals, if you're a doctor, right, you have tools that you use to do a surgery. If you're an engineer, you have tools that you use to go on the computer to fix a watch, right, to fix a drain. If you're a carpenter, you have tools. If you don't have the right tools, trust me, the work is going to be taking long. It wouldn't be coming out as good. And so you have to have tools. So in healthcare, there are now tools that are used that will allow, instead of saying that the nurses walked out on me and they are to blame, or the doctors want to go home and spend time in the clinics or privately and make money and don't stay in the hospital, because that affects one of the key performance indicators. The system doesn't blame the doctors. It blames the tool doesn't blame the doctors or the nurses or the maid who didn't clean the washroom in that hospital, or the engineer who didn't design the washrooms properly with proper handicap raising and all. It blames the system. It's a systems-based approach to healthcare quality improvement, and that is the enterprise risk management in healthcare, right? So it's a tool that is used, right? And it's based on 8 domains, right? The domains are very simple: operations, clinical safety, strategy, right? Finances, human capital, regulations, technology, and hazards. And those are the areas, those domains that you now have people who you're trained using the quality managers as quality risk managers. And when you train these people in all your RHAs, all of these 8 divisions, in identifying the risks, it is like I say, if it's a private hospital, you have to do it, because if you have somebody sitting down in your private hospital in a room for three days, or if you have somebody who's telling you that the toilet stink because your maid didn't clean it, you fire them. Well, in the public sector, you can't fire them. And Param, I'll tell you something. I was the medical director of a hospital, a public hospital, for 3 years. Good?
Yeah.
I had a doctor, right, who was abusing his senior doctors in front of patients, right? The guy was really rude to his senior doctors, and he was rude to patients. He was misbehaving. Good? We couldn't fire him under the civil service regulations that we have. It is so archaic and bureaucratic that under the civil service regulation, you can't just fire somebody as you would have to do it in the private sector, right? There was a process that you had to go through, right?
A procedure.
Yeah, you have to make sure and give them you have to go through what's called a grievance procedure.
Yes.
You have to make sure that the letters are written in. You have to go in 3 stages, right? And they have much more rights. And only if he commits a crime, right, can you actually say, okay, once he is actually guilty of that crime, then you could actually fire him or suspend him with pay or no pay.
Yes.
So it's not as in your country where, because of your governance system, It is because of our archaic public service laws, civil service regulations that allows people to continue to do this nonsense, right? So even if you bring in the accreditation standards and you try to bring them under the codes for it, it is a long process where even if they go to the industrial court, they might win. You know why? Because in the process, some of the other domains that I talked about did not come with the book. Like I went in the casualty and I went to the book. They didn't come with their book and say, well, hey, on so-and-so day, you said this. On so-and-so you said this. You know why? Because as the medical director, you do your part. But there are other people, medical records, finance, whatever. The people who comes into the hospital. Good. If I tell you that a doctor comes into my hospital at 8 o'clock and leaves at 10, how can I sit down with the doctor and show them that they actually did that in my hospital? I can't. You know why? Because when I was medical director and I told them, let us put an electronic gate on the car park doctors. So when they come in and they slide their card, it will go into a computer database and I will know when they come and I will know when they go. So therefore, when I came to my heads of divisions and my senior doctors in my meetings, I can't come and say, well, you only here for 2 hours because I can't prove it. So there are other systems like security, which would have backed up my statement to say, hey, you only spend 10 hours in hospital for the week when you should be spending 40 hours because we're paying you for a 40-hour week and you only spend 10 hours per week. No.
That's something that we have. That's a culture we have in Trinidad. The policeman come and punch the clock.
But you understand?
And he can't work PH.
We can't prove it. The reason why I was able to, I wouldn't say win over the nurses, but to get strength in my argument, right? Not being hauled over the coals was that I had the evidence in my diary. I recorded every single thing, right? That these same people who came to say, right, that they walk out, they shouldn't have walked out because we had a proper preamble. We did a proper process where they were informed and they agreed. You see, so that's when they had to back and come back to work. Good. But I don't have that for the doctors because I don't have the backup support from security to say that they actually spent 10 hours. Well, I can't still prove it, but at least if you go to, when I worked in Jackson Memorial, I parked my car, I slide my card, right? I came up to every single ward that I entered as a surgeon. I had to slide my card, right? And unless I didn't do that, I couldn't get access to the place. Every document that I had to enter my thing. So it means that somebody has an idea of why I'm trapped in that hospital during my 8-hour period that I spend there. You understand? So it means that if you are using a metric where specialist care, 40 hours of specialist care, you have been contracted to do that, but you are only providing 10 hours of that care. I can't win because I can't be justified in saying that you're correct. I can't prove it.
Yeah. You see, what is going on there as well is a culture that is implemented, doctor? A culture of don't care more about money than a patient.
But nobody to hold them accountable. The thing about there is no administration.
I want you to come back. I want you to come back. I wouldn't agree with you. You know why? Because I did the same thing when I was a doctor. And I mean, this is what happened. I was a consultant and I did the same damn thing. So the thing about it is, it's not really a culture. What it is I go back to the airport. When you go on a plane, right, there's a working system that you have to fall in line when you go to work on the first day. It's not about culture or bad habit. That is a system that works. So what we have to do is we have to institutionally strengthen the system. So that when my son now works as an ENT specialist, he will not fall into that bad habit, bad culture, because there's no culture there. There's a system that he has to follow, right? Yes. He goes to the hospital. He has to stay with his junior doctors until his shift ends as a specialist. He has a place to sit down, right? He has an area to go and sit down. When he goes there, he has a computer. He has journals to support him while he's there. You understand what I'm saying? He has a canteen or a cafe. Now, some of the doctors don't have that. They don't even have an operating canteen. The doctor's lounge don't have a working toilet. They don't have anything. They have no computers. The journals are not up to date. So that's one of the other guys on the 8 domains I'm talking about. You understand what I'm trying to tell you? So one of the domains that I talked about, they must do their part to support. If you want a doctor to spend 8 hours in a hospital every day instead of 2 hours, then you have to keep him there. You have to
environment.
you
Yeah.
have to make sure. So you can't blame the doctor for that culture problem. It's because the system that you have created for him over the years have been allowed to continue.
Awesome.
And the salary.
That's correct.
It's a systematic culture. It
Right.
existed.
But
Let me put it that way. It's a systematic culture.
But the airport, when you go to the airport to check in and you go through security, that's not a systematic culture. That's a system. The point about it is that it's not a culture, it's a system. So since 911, it became an improvement of a system that we had before. So what we have to do now is, from the time you go in there and you start blaming culture and blaming the fact that they don't care or anything, you're going to lose. So the trick is, now you have to use a tool, just like all of us using the proper tools, the tools that have been tested. So we now have to go and improve that system. We have to improve that system because we can't have your system of governance. So when I went to Cuba, Cuban system of governments compared to our system, where we have very archaic civil service laws, where we can't just go and tell a fella he's fired. You can't go and tell a nurse that they're fired because, first of all, none of those other 6-7 other domains are working properly to prove your case, right? To say, well, you attended that meeting, like what I did, and you said yes. Now, nobody can tell a nurse that, or nobody can tell a doctor that, because they don't have that backup data. Now we have AI. So now what we are hoping to do is that AI has to be integrated in our health sector in such a way that our two ministers will understand. They will get public administration and AI to come in with them, so that all the cyber hacking and things that they had before, they can put the necessary steps in place to ensure that when the medical directors who are hired, hopefully competent medical directors and not party loyalists, so that when they actually go in now, they can now sit down and say, okay, you know what, guys, I have a little problem. We are currently having I have 10 heads of department, 10 senior specialists, right? Each one of you all are supposed to work 40 hours of work week specialists. So that's 400 specialist hours per week, right? As of now, I am only getting 100. Now, I don't expect you all to change what you're doing now, but I would like to improve that to about 200, because I feel that if I get 200 hours of care, I might get some better outcomes. Could you? But no, I don't go. So you have to have data, right? So hopefully the AI would have some sort of supporting data that says, guys, this is not going between you and me. This is confidential, but these are your records coming into the new car park that the PNM built for the doctors in Southwest here. This car park is, you all slide your card when you enter. Well, this is just giving you an idea. It's not, it's not the best, but it shows that you are only spending 10 hours. Your car comes in and so and so, and it goes out, One of them, I say, well, no, my wife picks me up and she carries me, this and what, they might have other arguments, but basically your data show that. And you can now sit down as a medical director confidentially. Nobody has to know that, hey, you are not giving me 200 hours. You see? So this is just an example. It's not something that, I'm not going to say that this is what it is, because I don't want to get into trouble. But basically, this is the methodology that has to.
We have to have a monitoring system. We cannot continue the same way.
Correct.
Dr. Ramrup, you are very, very patient and very nice fella to say those things, I was one of the directors of the medical military hospital here in Venezuela. And when I say something, you run, you move, you know how we military guys are, right? Correct. So you were very nice, because we work 72 hours, 48 hours in one shift. We get into the hospital and that we don't know when we get out, right? Well, sometime when it was COVID, medical doctors were in there 14 days without going home. We just take a shower in the medical room, in the medical facility room and things like that, and change up and go again. Now, the training is very important. Training is very, very important. Commitment is very important. The salary is very important. Now, when we give the tools to these doctors, they have no justification to say no, that they are not doing their work. The tools are very important. Yeah. Now, when the blockage was here, we have almost 5,500 sanctions. There was no medication. There were no syringe or anything. We managed to overload all those things by hardship, right? And save life. We work with our fingernails. We did not have supplies. Now, these we cannot be so nice or so nice to people who are dangerous. I cannot go to a lion and say, "Hey, how are you doing?" and don't bite me. No, I move one time. If we, because sometimes we are being nice in a system, we destroy ourselves, right? There's something happened. Why Venezuela get into these ways? Because we forgive people who are not doing their work, people who are dangerous to the system, and they get strengthened. When they get strength, they destroy you, right? That is what went on here in Venezuela. Chavez forgive people who are very dangerous, people who are trying to destroy his system, and then after they get stronger, and therefore you get out of control, right? So if you get a doctor, the AI system, to a nurse or anyone, you pass your card everywhere you go. It depends, that card that you pass will be depends on your salary as well, right? You pass your card, your time, okay, you work 2 hours, you get paid for 2 hours. You work for 5 hours, you get paid for 5 hours. It's a good system. But speaking to the guy very nicely, hey, and this, no, that does not work with me. I go one time on it, and I got very high results, doctor. Very high results, right?
Well,
See, I mean,
I hear you.
that isn't healthcare. You can do that. There are certain things you have no control over.
Yeah.
Nurses, doctors, and electricity. Those three areas can cripple an economy the very next day. I saw it happen in Germany. In Frankfurt, they had some issue with doctors. Bam, 4 o'clock in the evening, 16,000 doctors, they just left their Mercedes in the Autobahn and they just park it up there.
And they're gone.
Next day, no, they stayed there in the night.
Huh?
They stayed there in the night. I couldn't come out my hotel to go where I have to go. So the next day they settled everything. Doctors are one people can hold the country to ransom. Nurses and electricity workers. Those three areas, they can hold a country to ransom anytime. It's not like you have military people who can take over, let's say, teachers or postmen and so on. They can go a week without school.
Yeah.
People can go a week without, meals delivered. You cannot go a week without electricity, everything. All elective surgeries have to be put off. All hospitals have to work with standby generators, which will conk out after a while.
Yeah.
Right? You cannot get power, energy, gasoline, diesel, because the pumps are using electricity. Every single thing demands electricity.
Yeah.
No computer system, nothing. It will work.
Yeah.
The day when the generator goes off, then what happens after that time?
Okay, you see what happened here in 2002 with the national strike here with the petroleum company, no? They completely, the petroleum workers, the strike and the President Chavez, former President Chavez, fired 18,000 workers from the petroleum company, and he sent the army to be trained in the petroleum companies as well. So we managed to have that time I was a young doctor as well. And I also went in to be trained in the oil field. So we have plan B, plan C, plan D, and we get to plan Z, we change the alphabet again, the strategy. So we have to have like what happened here in the petroleum company. The army now can manage the process of everything. Now, as I was saying, important, I cannot work without a nurse in the hospital, no? So this is why most of us, we look at nurses as also as doctors, but they don't have that the documentation to say that they are a doctor. No, plan A, plan B, plan C, and change the system and put more system in the more technology. Now we can have a very high infrastructure, as you said, Dr. Ramrup, the best. But if we don't have the human resource department or the human resources, when I say human resources, I mean the doctors and nurses, not the administrative office, no, the doctors and nurses with proper care as well, proper security, we would not have good health, right? Yeah. The maintenance of health is maintaining the personal or the personal, you say, the personal with optimization. You understand what I'm saying?
Yeah,
optimization.
Yes, yes. Optimization. The health of
optimization. That has to have the highest quality. Now, a hospital as a military doctor can be in a tent. Once you have the correct personnel there, there's no need for very expensive infrastructure, but we have to have very high quality and high training. I'm insisting on high training at all levels. Now,
we have to rewrite the SOP basically. We have to rewrite the standard operation procedure, and you take a few months and you restructure, and you make them sign. You spell it out what you want and what is expected. And like I say, you put them in a position where they fire themselves. Is either you comply, you stay your right out, but you have everything has to be supervised and managed, and we can't be buddy with this. You're playing with people's lives.
And you have to manage it with service level agreements to back it up, my friend.
Right.
SLAs, if you don't have SLAs, any system can collapse.
So unless we put the SOP in place and get an agreement on how we intend to manage. I mean, the population has clearly voted that they wanted an upgrade. We didn't vote to maintain the status quo. I keep saying we did not vote to maintain the status quo. Otherwise, PLM could stay right there. So it's either we have to put things in place. It will take a few months, and everything has to be spelled out. Dr. Ramrup idea and everybody, on the team in Trinidad, ideas have to come together, and we sort out how the things have to be written out, and then we move from there. But if we don't put that in place, I mean, it's like spinning top in mud. Go ahead, guys.
I really don't think that is their priority at this time. Everybody trying to get their feet wet in their respective ministries, try to address some of the low-hanging fruits. I don't know when they're going to do that. When are they going to look back and change the system?
Observing, our team observing and making and putting the recommendation. So when we get a chance to make that recommendation, we give them a chance to settle in. And we're observing how it rolling, and then we will say, hey, this is what we think should be done. This is where you want, if this was the objective, this is the manifesto or the manifesto. This is what we run on. So this is not going to happen the way you're going, and this is our recommendation. We had to recommend.
Yeah.
Go ahead.
I think that clearly, Mr. Singh, I feel that at this stage, which I think is the early stage, I know that they have made it quite clear in most of the ministries, not just in healthcare, that they are. I remember we had this chat a couple of days ago where we said, in order to know where we're going, right? In other words, to improve something, you must know where you are. You have to know what is current. You must know what your current status is. Mm-hmm. So my suggestion is that this is the time where I think that the Minister of Public Administration and AI, I think he has a very important role in this part of the process, right? Where he needs to even have a sit down with some of his other key ministers and bring in some of his subject matter experts, if they so exist within that ministry, because I'm not sure which one of the ministries that he would be using. Public administration would have been public administration before. But what I'm not seeing is, I feel I don't know if it's the previous Ministry of Digital Transformation or whatever it is. I feel that is the ministry. And I'm
It
not.
is.
Yeah, right. So if it is, then that ministry would come under his purview. And did you see a Ministry of Communication by any chance, or
No.
a communication department or anything, or would
No,
that?
no.
Yeah.
Not
Well,
at
I
all.
don't know, because I feel they would probably put it under the office of the Prime Minister. But in other words, then what I think is for public administration and digital, AI, I think that what they need to do now is we have to get some expertise, right, to work with the ministers, so that when they actually go in, while they are there now, and they first, because they didn't have a chance before, they won the elections, and then all of a sudden within a week they're now ministers.
Thrown into this.
So they haven't had that sort of workshop, right? A preparation workshop where they will come together. Hopefully, it could be done virtually. It doesn't have to be physically. And they say, well, look, hey guys, we have a little workshop where we want to give you all a little guide, right? To go through the next month, where we want you to be able to put in these necessary indicators in each of those different ministries that will be able to give us an idea of what their current status is, because we want to use that dashboard. So those dashboards
as a starting.
Right. So we want to use those dashboards as your base dashboard, right? And then we're going to go now in the next, every month, every 6 months, or whatever your boards, if you have statutory boards, they have to report on those KPIs, right? Every month when they send in their statutory board meetings, to you, right? You have to now report on those KPIs, so that what we're going to do, we're going to check each one of those as you go forward, right? Because that is what you'll have to improve at the end of your 5 years, right? We'll look at a midterm review. The Prime Minister obviously would have to look at it and say, well, hey guys, looking at what it is, you guys were here and I see you've gone there. But in other words, then I think now, since they're saying that they're trying to assess where they are, that some degree of help should be given to them to develop those dashboards, so that each ministry would have specific KPIs that they will have to measure now to say, well, look, this is where we are. Yes. And so that the ministers now, when they're having their cabinet meetings or whatever, if they have their business meetings or whatever, they will have those KPIs now on their desktop to say, well, look, okay, guys, this is where we are, and this is where, if it's my idea or Ramrup idea or whoever idea or scientist idea or my subject matter experts from the ministry, my technocrats, they are the ones who are going to be improving it. This is where we're taking it to. What do you guys think? Because I think that is something that could be done in this phase to help these guys say, okay, this is my assessment of our current status. And therefore, to improve it, I'll have to improve what we have here. Building dashboards is not a simple thing. Not everybody knows how to build
dashboards. You have to know your priority. Again, the metrics is the thing. Metrics, KPIs, benchmarking. Your strategic goals have to be identified upfront, and how you link your metrics with the KPI with the strategic goals. It ties back to your personnel, your HR capability. And if your HR capability is the problem, we'll make sure that this thing is not fulfilled. So you will never achieve your strategic goals. And the problem that they're going to face right throughout their 5 years is that HR capability, who is really the hardcore supporters of the PNM.
I think
they are with you. You think they are with you, but they are not.
I think we should have a party think tank, right? Which is like a managerial party think tank that says, okay, guys, send us the strategic plans of all of your ministries, because every single ministry of government should have a strategic and business plan, right? If they don't, I'll be very, very worried about that, because
they have the manifestos and they're using that as their plan.
Right. So every one of them should have that. Since you are a new minister there, you wouldn't have the time now to go and read that. I can tell you. So what we can do is send it to this think tank, right, Gary? Let's create this think tank. Send it to the think tank. Let us go through it, right?
You have to map.
Let us map everything that the outcomes that these ministries were supposed to have done, right? And you could do your internal interviews and whatever. We'll guide you as to what exactly we want the answers for. In other words, then these are some of the things we want you to give us back this. You know what I mean? In finance, you will have certain key indicators. In health, you will have certain key indicators, blah, blah, blah. Let us get those from the people who you are dealing with now, right? And send it back to us. And we will develop your dashboards for you, right? You could go ahead and do what you want to know. Continue with what you think in your night on your bed you want to do. You want to put in, man, you go ahead. This is what you have to do, fine. But we want to align it back to that strategic plan. Good. And we want to tell you what you have to measure, right? And if you do that, Chief, I am positive that you would get somewhere within a certain time.
Within a certain time frame. And you remember, you only have 3 years to do that. Eh?
Correct.
Now, on top of overriding all of this is your 11 or your 13 growth poles.
Good.
Every ministry has an input in the achievement of the growth poles. So, let's say you want to develop your tech and AI, right?
Yeah.
That is a growth pole to develop adequate HR capabilities for people with technology and AI. When is that backward chaining process? It ties back to the curriculum in the secondary schools. So the secondary schools have to start changing their curriculum to suit what type of students you want to have that will man the AI and technology department when they come out of school. Mm-hmm. So you have to have that chain of command right through, and it starts with the curriculum. Now, if you're just doing the normal curriculum to study AI and technology, you start to need, core of that is basically mathematics, some programming, and statistics, because the fuel for the whole AI and technology trust is data. Mm-hmm. And if you don't have data, you can't. AI is useless. AI only uses data, nothing else but data. So you have to know how to collect the data, you have to know how to store it, this, that, extrapolate, and like a dashboard cell, you can see trends, you can see performance, you can deduce a lot of things from the data, and that is what AI helps you to do. Mm-hmm. Right? You have to know how to interpret. Okay, we all do statistics in our schooling, but do we understand the meaning when you say the mean root squared is 0.75? We get the sum, the mathematics sum correct, but do we know how to interpret that? Do we know how to interpret what is standard deviation or two standard deviation? Do we know we can calculate it? Yes, 0.96 or whatever the fraction to two standard deviation. Do we know what that is? And this is what AI will help you do. AI will tell you, okay, in the health system with two standard deviation, this is what it means. So you see, it all ties back now. If you want to do this technology and AI sector, that will man the 11 or the 13 growth poles that we want to develop. If you want to develop that, you need to have the skilled resources. And if you do not tie that back with the curriculum, what's going to happen?
Yeah.
So it has to be a process. I don't expect the ministers to see that, but this idea, to say the think tank, that is so critical. This will look at all the ministries and all their problems, and we can tell you exactly where we're going and what should be done to counteract the problems you are going to face in your particular ministry.
Yeah, I think it's something that the party needs, because I think if you look at each minister doing his own work in his own ministry, right? He's trying to assess his current state, because he's coming in after 10 years of another party. He's now, some may have had experience with being previous ministers, but most of them are green. They're coming out to the ministry, and then they're going to be saying, look, I need to do a gap analysis. A lot of them wouldn't have the skill to do a gap analysis.
Exactly the point.
You would have your technocrats within the ministry. A lot of these are subject matter experts, and some of them are unqualified. They are just deputy permanent secretaries that have come up the rank.
Correct.
In some of those ministries, they would have sent some of the technocrats to train, spend money on them to go workshops and whatever. These people would have come back and said, well, this is the current contemporary policies that, but based on a workshop that we did in Geneva or wherever it is, and this is what they are looking at. This is the climate change policy. These are your growth goals that they're talking about. This is blah 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 blah. But in order to bring it in, a lot of those policies are based on an inter-ministerial collaboration. A lot of these ministries are. I mean, if you look at at climate change, if you look at peace, a lot of the policies for global economic development, your growth goals, and all of these involve other ministries.
Yes, it does be coordinated.
There is absolutely no interministerial collaboration in driving national policies on some of these areas which actually need these different divisions to come together. And if you are saying that public administration and Ministry of Planning and Development are probably the two ministries that are going to be orchestrating this interconnection of data and data mining, data transfer, data sharing, all right, within the ministries, and planning and development is actually now going to be taking these policies that come out of that and saying, well, look, this is where I'm going to go in the next 10, 15, 20, 25 years, then those ministries needs to really work with the current ministries now in doing the gap analysis, because the gap analysis is going to tell the government where and what they have to long-term wins.
Yeah, I agree. I sat down yesterday and today I'm thinking about this, and there are so many gaps.
Yeah,
they will find per ministry. There'll be several gaps in a particular ministry that needs to be. And I was looking specifically at public administration. They took over that digitization and digitalization department, right?
Yeah.
Then there's a technology, AI, social media, and something else. All that is coordinated to one guy.
Yeah.
I don't know how experienced he is. Young, I look at him like a kid.
Yeah.
Dominic Smith.
Yeah.
Right? I don't know. That should be at least be shared among. Is he and he alone, by the way?
Yeah.
He doesn't have a parliamentary secretary. He has no support as other minister in the ministry there.
Yeah.
And that ministry is perhaps the most critical.
I think that in this
drive the reform,
yes,
which will make sure that your policies and so on, or whatever project you have planned, doesn't get, sidelined, stopped, deliberately, putting all these spokes in and you cannot achieve no
planning and development and the research department, the data collection department, the census department, that ministry will hold the data. And therefore, it is important, I think, for the two ministries, public administration and planning and development, to work very closely together. And I think that part of the initial phases, I mean, we talked about in our talks about doing an audit of the COVID-19 management. That needs data. That needs the data that would be sent in, collected by the ministries of health, the registration areas, right? The registry. It would have that data would go up to the Ministry of Health. It will also go to the national where all data go in. It will be Ministry of Planning, where they will actually get all the data from all the different sources, and they will be having that data stored in a database so that they can use it later for their census and for their statistical digest that they put out every so often. So
let me give you an idea.
How much you think these guys have documented? You think they have a lot documented?
The thing is that the system with respect to death certificates is a very, very rigid system in Trinidad. Once somebody gets married or even if they're born, sometimes that falls through the crack. But once you die, pretty much to bury somebody, the police or the DMO or whatever it is, you have to have a death certificate.
Mm-hmm. And but not only that, I'm talking about how the whole operation went, with how the money spent.
You mean COVID and thing? Well, no. You see, what I'm trying to say is that when you look at how that is going to be managed, that'll be part of it. But what you have to do, you will have to get you'll have to get a global indicator that shows what was the actual impact of the COVID on the country. And to start with, you'll have to know your mortality rate, okay? Because it's based on your mortality rate. That is in other words, and it's like an outcome, right? Yeah. So in other words, and it is going to tell you whether it was bad or good. You understand? So if you see that your mortality rate compared to the global mortality rate was actually really good, then, you know, for what it's worth, it might be a waste of millions of dollars now to go back and do a big thing. If it was handled damn good, I mean, according to the one or two of the basic indicators. So I think that once you get an idea of how we compare to the other parts of the world, similar sort of countries, 1.3 million, similar sort of health resources and all this sort of thing. Those are data that we need. And it's not just the death rate, but other things, because we would have had our economic system, you know, what was the HSF fund, you know, how many persons, you know, actually how many doctors we had in the system, how many nurses, all of that will be information that we'll be using in that audit. So it's not just the death rate, Gary, it is everything, but the death rate will give us an idea of what exactly was done, you know.
Let me give you an example how it turns out. As director of tourism in Tobago, I had to collect information, or it was my R&D had to collect information about the tourist arrivals in the airport from, let's say, British Airways, Virgin Atlantic, Martinair, the various airlines that fly into Tobago directly. But that information they will not give me. I'm the director of tourism and I have to beg for that data. And they will not take it. CSO said, immigration said that is their data. That data cannot be shared. That data has to go to CSO, which falls under planning, and it takes me 2 years to get that data. 2 years. I had to send an employee from my division to actually go in the airport and check everybody coming out the flight so that I could get data. And why I needed that data. I needed that data to tell me whether I need a next flight, whether I will start negotiation for a next flight out of Germany where Condor can fly, or another. I need that data to tell me, hey, you know what? I need another flight to tell British Airways or Virgin Atlantic to, you know, bring another flight off to the UK for me. I needed data. How can I back it up? I just can't go and say, hey, you know what? I think you should do another flight for us. With what? Why is my data to show that, you know, we haven't? So it took me 2 years. And the only way I can circumvent that was to send a person every day when a flight comes in to check and tell me how much arrivals we are having.
Yes.
So you see what happens. This is what happens.
That
system. Who has the control of the data?
And
now, as I keep on telling you, AI runs on it. This is 10, 15 years ago. Can you imagine now? If you don't have that, you cannot plan nothing.
There's a lot of work that needs to be done.
How many people you could get? You know, I mean, we have our UNC USA think tank right here. I want to build out this team so that we observe and compile the data as we see happening. So if you guys have anybody that can communicate with you to give you some feedback so we can document things as we go forward, then we will make a recommendation to the Prime Minister herself, you know, and let her implement, let her deal with her ministers, you know, her various ministers. We're not going to send them to the ministers. We're going to make the recommendation to the Prime Minister and let the Prime Minister delegate to them, because some people might think that, you know, we'll be pushing our luck or whatever it is. So what I'm saying to you is I am asking this team here to observe, report, and analyze and make some recommendation so that, you know, so that we can, it's part of risk management. We CYA, basically, and we don't want to see, I don't want to see our Prime Minister gets blindsided, right? And that is my number one objective, is that she has the right information. Let her make the decision, but we're making sure we give her the right information. How she acts on it is her choice, but we want to make sure she knows. right? And if we can do that, that is what I'm looking for. I am trying to protect my country and also protect my prime minister at the same time. And my relationship with her is because we have so much love for her. She's like an aunt. A family. She's a very down-to-earth, caring person. We connect with her like that. So the extra interest, it's not just an ordinary prime minister. It's an extra interest here because how we feel about her.
I agree, and what I wanted to suggest is working hard and working smart instead of working hard. I think there are two government ministries: Ministry of Planning and Development and the Ministry of Public Administration and AI, that is supposed to do this for ministers, right? I think that the fact that they would not do it because of the way that the ministries are set up and whatever, it is possible that since the Ministry of Planning and Development have the data, right, it's there, and the Ministry of Public Administration is supposed to be the ministry that administrates the public service, all the different ministries, to bring the key relevant information that needs to be shared, including data, right? Whether it's confidential or not, sensitive or not. And that is why I had mentioned in an earlier post, we need to have levels of security, right? The reason being is that if we create levels of security through the national security mechanism, certain persons can be given levels of security authority, right?
That was created under Windows back in the day when 2000 was coming out. You're building out.
Yes. So that level of security means that certain data can actually be accessed by certain persons in a ministry, and they are basically
certain amount of data rights.
Right. So that may if I am saying that I need a certain a number of data from the immigration department. Okay, it means therefore that the actual data set can be sent to that person. And then if I ask for the certain elements of that data, right, it can be done. AI can take what it wants from it without giving me the confidentiality or the security issues related to that immigration document. So I think that by creating that, even having meetings, you would have certain people going into a door and not other people. You know what I mean? That security levels of clearance means that phones and whatever, like when you go to the US Embassy, you have to leave your damn phone outside. I think that in certain cases of where people are going to meetings with ministers and whatever, the phones should be outside, unless you're a doctor or a military person in a severe. You have to leave your phone outside. So these are things that all these levels of security, not just physical security, but cyber, and all of these, all these factor identification thing, all of those things throughout all the ministries. I think that has to be done, and I'm not sure what digitization was doing in the last 10 years. Maybe they are
zero.
Maybe I don't know. I mean, I haven't gone back in the ministry, so I don't know. But these are things that are very relevant going forward, and I'm hoping that maybe what we need, Gary, is not a whole team of 15 people. It's just maybe about 5 or 6 persons that when we explain to the Honorable Prime Minister, this is what we are doing, right? We just want to have the ability through the line ministers to engage the technocrats, right, who have been hired by government, right, to create the necessary dashboards to administrate the public service and give these dashboards to the ministers, right, so that they can begin their orientation, their understanding, their gap analysis, so that they can give the Prime Minister and a cabinet an idea of where these ministries are currently at this point in time. Yeah.
But can you? This is what I'm asking you guys to help me lay out that in your recommendation.
Yeah.
Right. Help me lay out that, and then we make a recommendation to her. Our job. This is my mission. Our job is to communicate with her directly. Like I said.
So
let her decide.
Yeah.
How she's handling it.
Right.
But I want to make sure she knows.
Right. I think that what we can do is use what is there already. Right. I don't know if you know. I mean, I'm not sure if Mr. Singh knows. Each minister normally, sometimes, I'm not sure if it's in the budget, but they normally, I mean, they have the parliamentary secretaries, right? Sometimes they used to have an advisor. Sometimes they used to have a person who used to be like the advisor. Okay. So if there is no advisor in this government, and maybe the parliamentary secretaries are the ones who actually are something like the advisors to the minister in those relevant ministries, then they are the ones who we could actually be able to put into that recommendation as the persons that we'll be able to engage with, right, with respect to public administration and planning. What do you think about it? Mull it over. I could probably develop
as you think about it, I want you to put it on paper.
As I'm saying, I will develop a sort of position paper, a paper that we could send out for you guys, and maybe while you're looking at it over the next week, maybe you could just see if you could incorporate any other person whom you think might have the ability, as Mr. Singh, to look at some of the, what we should say, the administrative and strategic intent of what we are saying, in the sense that we will be almost like advisors using the technocrats of the ministry who have been hired by government to do these things, right? To provide those based on our terms of reference, right, which we'll provide to the Honorable Prime Minister to pass on to the Minister of Public Administration, so that the Public Administration Ministry, I'm just giving you the sort of idea of what it was going to be like.
Well, like I said, put it together. We make the recommendation, and we are here to supplement.
That's the concept. That's the concept document or the concept strategy. And if you guys are okay with it, I'll formulate it and send it to flesh out. Okay.
I am okay with it, and I have a lot of confidence in you in doing that. And between you, Mr. Singh. Mr. Singh has been on the ground, and both of you have been in government. You know how it's supposed to operate. So definitely. And then we have Mr. Fawaz, the medical thing here. Also, we have Mr. Dr. Parum Miraj with us here. So I say put the pen to paper, draft it up, and let's get it out. Creating a basic structure first, and then we build out on these points. Afterwards, you could collect you physically on the ground. You could collect information and get feedback, on what's happening as we go into government and what is needed. So we're gonna monitor this thing, all right, and then we're gonna make our recommendation as time goes by. Okay. All right. So with that, I would say, Dr. Parum, you have any recommendation? Anything else you want to say?
Not for now. Let me analyze everything again. Well,
a lot we wouldn't be able to say publicly. We know that. So we'll have to build out this thing, and then Dr. Ramrup is there on the ground, and he can handle that from that point there. So with that, gentlemen, I will say good night. Thank you for taking so much time with me tonight, and deeply appreciate you taking the time. All right. Good night, everybody.
Good night, Doctor. Good night.
All right. Take care.
And I want to thank our listening audience for listening, and hopefully that we give you some good education and information here tonight.
I hope I meet you personally soon, Dr. Ramrup.
Sure. When you go to Trinidad, you have the number.
Send a helicopter for me from Venezuela. I'll fly and check you, and you can come back. No problem. I'm not too far.
Yeah, but some medical doctors were trained to fly helicopters here.
All right. Okay. Good.
Right. Also, Dr. Parum, I would like you to visit Farida and see what her mother's situation there, so you can give an analysis.
Send her. Send me her number.
I'll send you number as soon as I get upstairs. I'm now getting home here, so I'll send you number as soon as I get up.
Okay.
Guys.
All right, guys. Good night.
Good night.